Hi everyone, and welcome to Fundamentals Chapter 25, Mechanical Immobilization. The learning objectives for this chapter include the following. List at least 3 purposes of mechanical immobilization. Name 4 types of splints. Discuss why slings and braces are used. Explain the purpose of a cast. Name 3 types of cast. Describe at least 5 nursing actions that are appropriate when caring for clients with cast. Discuss how casts are removed. Explain what traction implies. List 3 types of traction. Name 7 principles that apply to maintaining effective traction. Describe the purpose of an external fixator and identify the rationale for performing pen site care. Well, what is the purpose of mechanical immobilization? First of all, it relieves pain and muscle spasms. Next, it supports and aligns skeletal injuries. It also restricts movement while injuries heal. It provides and maintains a functional position until the healing is complete. It also allows for activity while restricting movement of an injured area. And it prevents further structural damage and deformity from occurring. So this is a picture of a splint. This is a temporary splint, and they can be commercial or inflatable. This is an example of an emergency splint for a leg. And when you apply an emergency splint, the nurse should avoid changing the position of the injured part to prevent any additional injuries. This is what an inflatable splint looks like, and this is for the arm. Immobilizers can be molded or cervical. This is an example of an immobilizer. Cervical collars can be rigid or soft. When wearing a cervical collar for a prolonged period of time, that can lead to some permanent stiffness in the neck. But depending on the injury or a client's diagnosis, they may be required to wear a cervical collar almost continuously for a period of 10 days up to 2 weeks. Now, these clients can remove them and do some gentle range of motion, some gentle neck exercises, and the sooner the client starts performing those exercises, the faster the revascularization and the recovery can occur. Now, say a client has a slipped disc. The nurse assesses the client's neuromuscular status by having them or her wear a cervical collar. The nurse would also perform movements that correlate with muscular functions controlled by the cervical spine and the peripheral nerve roots. Now, it would be a nurse who is specially trained in this area to do this type of assessment and to apply that type of collar for that procedure. This is an example of a molded immobilizer that's used on the lower arm. Other mechanical immobilizing devices can be in the form of slings, which is a cloth device used to elevate, cradle, or support an arm. You'll see a sling sometimes used in a client who's had a pacemaker placed. A brace is a custom made or custom fitted device. Some types of braces include prophylactic, rehabilitative, and functional. So here we have an example of types of braces. We have a knee sleeve, a rehabilitative brace, a prophylactic brace, and a functional brace. So a brace, as we already said, is a custom made or custom fitted device that's designed to support weakened structures. So the functional brace is most suited for the client because they provide stability for an unstable joint. So functional is an unstable joint. A prophylactic brace is used to prevent or reduce the severity of a joint injury that's already occurred. Then your rehabilitative brace allows protected motion of an injured joint that has been treated operatively. So with your rehabilitative brace, they have that on after they have done their surgery. So that's when you would use the rehabilitative brace. So now we move on to cast. And cast are made of plaster of Paris or fiberglass, and they're used to immobilize injured body structures. We have cylinder cast, body cast, bivalved cast, and spica cast. So a fiberglass cast is durable, is very lightweight and porous. It allows immediate weight bearing and is unaffected by water. However, it is expensive compared to the plaster of Paris cast, which is inexpensive. And a plaster of Paris cast is easy to apply but is heavy and is also prone to cracking and crumbling. So, whenever you are assisting with the application of a fiberglass cast, you only open those packets one at a time, but you only open those foil packets that has the fiberglass in it one at a time. And that's because they dry rapidly, and when they get dry, you can't wrap them or use them. So know that that fiberglass is very fast drying, and you can only open those one at a time. So you're only going to open them as the doctor says he needs them. Regardless of whether you apply a plaster cast or pre-moistened rolls of the fiberglass, the nurse always washes the client's skin with soap and water and dries it very well. You're going to cover the skin with a protective padding, and then the nurse should also administer any pain relief medication to the client if it's prescribed by the physician. So a cylinder cast encircles an arm or a leg and leaves the toes or fingers exposed. The cast extends from the joints above and below the affected bone in order to prevent movement and maintain correct alignment during healing. The most important action when removing a bivalve cast is to remove half of the shell temporarily for hygiene and assist the client to a prone position when removing the posterior half of the cast. And this is usually mostly for upper body extremity. Your bivalve casts are used for your arms or your upper extremities. Now, a body cast that encircles the entire trunk of the body. So here are some examples of various type of cast and what they would look like or what body part they may even be on. Keeping in mind that with our elderly population, if they have like an upper arm fracture or something like that, they're probably not going to have any surgery. More than likely, they're going to get that cast on that upper arm or that upper extremity. So they may have to have occupational and physical therapy to help them regain any function or loss of range of motion during that time of immobilization. And that will also help to prevent or decrease any permanent loss of function. Always identify the neuromuscular function of the client. The nurse should monitor the mobility of the fingers and toes at all times. You need to make sure that you're going in and looking at those fingers and toes and making sure that the client can move them, that they're warm to touch, that they're pink in color, that kind of thing. So you want to do those neurovascular checks on the client's extremities. So when we talk about cast application and cast care, as you see, there's a lot of information here to review. So the skin condition of the client, you need to make sure that it's documented before the cast is put on. You want to make sure that if there's any wounds or visible lesions present whenever the cast is placed, you need to make sure you document that, because any open skin area under that cast is risk for infection. Circulation. So does the client have good circulation before the cast is applied? If they do, and then you need to make sure they have good circulation after the cast is applied. What's their capillary refill? You need to be looking at the capillary refill before and after the cast is applied. And of course, mobility. Can they wiggle those fingers? Can they wiggle those toes? Sensation. Can they feel you when you touch their fingers or toes? Because you need to make sure that you are documenting that good sensation. And the position of the extremity. So if they have an arm cast, you want to make sure that they keep it elevated whenever they're sitting down. They don't need to hang that arm down. If they have a leg cast on, they don't need to be sitting in that position where that leg is hanging down. They need to elevate that leg, keep it elevated as much as possible. You want to avoid getting that cast wet, even if it's a fiberglass cast. I know that that's more water resilient, but consider a wound or a lesion that's up under that cast. You want to avoid getting that cast wet. If it does get wet, use a blow dryer on the cool setting. You can do that to help dry out that cast. Tell your client not to insert objects into the cast. So you don't want them to take that pencil and scratch down in that cast, or that coat hanger and scratch down inside that cast. Because if they scratch inside that cast, they can open the skin. If they open the skin, then they're at risk for an infection up under that cast. But if the client says they're itching, or this cast is causing me to itch and I have all this itching, well, then we need to try some medication, maybe like some Benadryl, diphenhydramine. We need to try some of that to see if that will help their itching. They can also use a cool hair dryer. That can also help the itching. They can turn that hair dryer on the cool setting and blow it down on the inside of that cast. That will help some of that itching. If you have any foul odor or drainage that you see coming from up under that cast, probably got an infection up under there. So you need to let someone know and report that immediately if you see that. So like I said, always perform those neurovascular checks on those extremities. Look at the mobilities of those fingers and toes. Know that the application of a cast can result in compromise of the vascular nerve function of an extremity. The lack of movement of an extremity can indicate a neurovascular compromise or compartment syndrome, and that warrants immediate notification of the provider. That capillary refill is on the distal end of the cast. So that's on the opposite, end of the cast. If you feel any warm areas on that cast when you're doing your assessment, anytime you're assessing that cast and you're running your hands along that cast, if you feel any areas of warmth, know that that could indicate an infection. Make sure, like I said, you elevate that extremity, that casted extremity. Make sure you elevate it. Do not place it into a dependent position. Do not put it in a dependent position, because if you do, you're going to have swelling in that casted area and you're going to have pain with your patient. If you have any skin irritation along the edges of that cast, you see what's rubbing the skin. You can actually do what's called pedaling. So you can overlay some strips of tape over the edges of that cast to prevent any irritation on the skin. So remember, I told you about elevating it, right? Keep it elevated. We don't want that dependent edema to occur. So you elevate that casted. If it's a leg, elevate it higher than the client's heart. And that facilitates venous return of blood from the distal area to the heart. You can also apply some ice packs, and that can help with some of the pain, but you only want to keep that ice on temporarily. That helps with the pain and with swelling. So just keep it on 20 minutes at the time. You're going to have to refill that ice frequently. Ask that client to wiggle those toes. Every time you go in, ask them to wiggle it. And whenever you're not in the room, tell them, say, about every 15 or 20 minutes, wiggle your toes, keep them moving. Exercising those toes helps contract those skeletal muscles, and that compresses the capillaries and veins, and that propels the venous blood flow back to the heart. So you want to tell them, keep wiggling those toes, keep wiggling those fingers, keep that blood flowing and moving back up to the heart. We don't want any of that stagnation there. We want it to keep moving. So pain that is unrelieved by elevation, cold applications, and analgesic medication. Pain that escalates and does not respond to any of these measures is potentially compartment syndrome, and that should be reported immediately. Now, it's not unusual for a new cast to have a little bit of swelling, but it can become too tight. If it becomes too tight, it starts to obstruct that circulation, and it can have nerve damage. So you need to monitor the client for pain unrelieved by routine medications. The client may have numbness and tingling. The skin is cold to touch and pale, and that's an identification of compartment syndrome. All of these things are. The unrelieved by the routine medication, numbness, tingling, cold to touch, pale. That's an obstruction. That's compartment syndrome. That has to be reported immediately, because that cast has to be removed immediately. Failure to remove the cast immediately will result in permanent damage to the nerves. Now, removing a cast has got to be a scary situation whenever someone's coming at you with what looks like to be a skill saw. You have a fear that that's going to cut into your leg. Can you imagine how children would feel and how scary that would be? So that cast removal, we're going to use electric cast cutters. And like I said, that can frighten a person. Not just the noise, but the fact of that blade rotating around can be scary enough. Whenever the cast comes off, you're going to see unexercised muscle there. So that skin, that muscle may be a little bit fragile, may look smaller than the other one. You're going to have some limited range of motion with that extremity as well. That skin's going to be dry and scaly. You're just going to wash it with some warm soapy water and apply a lot of moisturizer, a lot of lotion to that. Like I said, unexercised muscles usually appear smaller and weaker. That cast remover, it's electric. It looks like a little small circular saw. The proper use of an electric cast cutter leaves the skin intact. There's padding up under that cast. You'll see that padding. They put the padding on before they put the fiberglass or the plaster of Paris on. You'll put that little padding there. And then you just cut that manually with some clean scissors. Just remove that padding. And if you have to pry the cast open a little bit, it's just the use of some forceps or some hemostats or something like that would just help pry that cast apart to get it off the client. Traction. Traction is the pulling effect exerted on a part of the skeletal system. Now we use traction to reduce pain, reduce muscle spasms, to realign bones, and to prevent deformities. It is a pulling force that aids in healing and relieves the symptoms. Like I said, it also prevents any trauma. You have to maintain a functional position until the extremity is healed. And it supports and aligns those skeletal injuries. So as you see on this diagram, there's what appears to be a small square at the foot of that bed that's hanging. That's actually the weight. So if the weight is touching the floor, if that weight slides down and touches the floor, that's because the patient has slid down in the bed and that weight's touching the floor. That means that traction is no longer effective. So you have to get the client pulled back up into bed. The weight has to be off the floor for there to be proper traction on the client. To maintain the effective traction, the traction weight should be suspended without interference and not touching the floor. The nurse should keep the traction applied continuously to get the desired effect, unless there are medical orders otherwise. The nurse should always check the prescribed amount of weight that's been ordered and make sure that it's applied to create the necessary pulling effect on the affected body part. There are various forms of traction. There's manual, skin, and skeletal traction. As you see here, I have a shoulder dislocation, which is a manual traction, skin traction, and a hip dislocation reduction and traction pinning. Take a few minutes, click on these links in the PowerPoint and watch these videos, especially those of you who've never seen traction or seen traction applied. It's going to be most helpful to get those visual pictures. So manual traction is used to realign a broken bone or replace a dislocated bone in its original position. And that's what you'll see when you look at this shoulder dislocation. You're going to see it takes a couple of people to pop that guy's shoulder back into place. Skin traction is a pulling effect on the skeletal system done by applying a device to the skin. So it's actually done with some tape and levers, that kind of thing, but it's not pinned into the body. That skin traction is an excellent video. Be sure to look at that. Your skeletal traction is, like I said, the pull exerted directly on the skeletal system by attaching wires, pins, or tongs through a bone. And when you look at the hip dislocation, they're going to actually do some pinning with that as well. So you're going to actually see them do the pinning for that traction. So if your patient has traction, especially skeletal traction, there's going to be pins attached to the skeletal system itself, and that's going to set the client up for potential infection. So follow the guidelines of the facility or the doctor's order as far as cleaning the pin site, Usually it's with normal saline or hydrogen peroxide or wound cleaner. We never put any ointments or creams on the pen sites themselves. We want to keep those open and dry and reduce any chance of any microorganisms from developing or getting on those pen site areas. You make sure that you keep those areas clean. If you notice any temperature in your patient, any redness at the pen sites, any drainage at the pen site, swelling, if the client has an elevated white count or pain at the pen site, that's going to be some of your signs of an infection. If you notice any drainage, you definitely need to get a wound culture so that we can see if there's any organisms growing so that we can treat them effectively if they have some type of infection going on. So this is an example of an external fixator. You may see this with foot surgery or lower leg surgery. It screws that are placed in the bone, and it just keeps the bones lined up. It realigns the bone. It's a metal device, and it is surgically inserted to stabilize that. You have to encourage the patient to stay active and mobile even with this external fixator on. You want them to continue to be mobile and move because you know what happens if they remain in the bed or they don't move. They can develop a lot of complications, so we want to keep them up and moving. And these are just a few of our nursing implications, our nursing diagnosis, and they could be acute pain, risk for disuse. Um, Disuse can also occur with the application of a cast or traction or something like that. That external fixator that can cause disuse. And self-care deficit, especially bathing and hygiene. So know that your client who's in traction is going to need some help bathing. That person who has the cast on is going to need some help bathing. Even to get up and go to the bathroom is quite a chore for some of your clients. So make sure that you are attentive to those clients' needs. And that ends our discussion for Mechanical Immobilization, Chapter 25, Fundamentals. Thank you.